Hi everyone, my name is Eric Levasseur, paramedic practice coordinator with Health Sciences North Center for Hospital Care. In today's presentation, I'm going to go over our 2020 spring rounds presentation, and the segment here particularly that I'm going to cover will be 12-lead ECG review, as well as STEMI mimics, some STEMI mimics for that matter, and V4R and 15-lead. So without further ado, I will begin the presentation. So 12-lead review, as some of you guys may remember, there'll be a lot of familiar slides as we've covered a lot of this material the last couple of years. We feel that it's important to always review to make actually paramedics more comfortable when reviewing 12 leads. So this is obviously a good review for everybody. So disclaimer here, as we see in the first slide, infarcts can occur but show relatively little ECG change, aka known as non-STEMI. So to ensure to fully assess, treat, and transport your patient appropriately. So this message also just reminds paramedics that the added addition of the 12 lead is an added tool. And therefore, when looking at 12 leads and making your interpretation, it's important to remember that although you may not see ST elevation changes, it does not mean that the patient is not having a STEMI or an MI. So it is important to acknowledge that you're treating the patient and not just the monitor, and therefore if they're exhibiting signs of ACS, that you should treat this patient regardless of what you're seeing. It is also important to reinforce the fact that in a non-STEMI 12 lead that's presented, you may want to repeat your 12 leads to ensure there's no change and STEMI hasn't developed along the way. So in a non-STEMI patient, again, just a reminder to actually repeat your 12 leads when possible to see if there's any changes along the way. If we look down to the diagram that you see about the heart, we got coronary artery occlusions. So you'll see a listed number there of 1, 2, 3, 4, and 5, and 6, each describing what the locations are. These numbers are referring to the fact that these are the common locations where artery occlusions commonly occur. So when you're looking at a STEMI, and if you were to pick up a patient who's developing a STEMI, chances are you're going to see the location that is occluded are going to be represented on your 12 lead. So the common ones, if you can see there, it's coming down the ALAD, or left anterior descending coronary artery. Those typically, your number one, oftentimes occlusion would be kind of a septal anterior MI. Then second to that, you can see occlusions on the right coronary artery, so that'd be number 2, and those would be usually distinguished when you're looking at a 12 lead and diagnosing them as a inferior MI. Then third would be a circumflex coronary artery, and those would be represented by a lateral MI. And then 4, 5, and 6, as you can see, are probably less common. The 4 would represent probably your AVR STEMI, which, although not very common, but still not uncommon to occur. So the occlusion of high left main stem coronary artery occlusion. And then 5 and 6 are your posterior MIs, which aren't typically common, but of course still do occur. And with the presence of a 15 lead will allow you to establish and determine that the occlusion is on the posterior side. ST segment elevation, STEMI. So to presumptive evidence of AMI, so you need to see ST elevation on the 12 lead, and that's the reasons why you're performing a 12 lead to begin with. So when you do see ST elevation MI, it's an indication for acute reperfusion therapy. So that's why we therefore have a STEMI alert. Those who are working in a Sudbury area will have a cath lab bypass. And of course, it's only for the Sudbury proper, as there is no other cath lab in the Northeast region. ST segment elevation measurement, so 0.04 seconds after the J point is the official measurement that we should all use when we're actually measuring ST elevation. So as you can see, the J point is located at the end of the QRS complex in the beginning of the ST segment, and the J point, as you can see in the picture diagram on the bottom, you can definitely identify the end of the QRS complex in the beginning of the ST segment again. when it comes to measuring, you first have to find a location of the J point, and then one little square box over to the right, you do your official measurement. So that'll be at 0.4 seconds to the right of that J point, and that will be your official measurement when you're determining ST elevation. AMI recognition. So what are we looking for? So as we just mentioned, we're looking for ST elevation. And more specifically, we're going to be looking for at least 2 millimeters of elevation in leads V1, V2, V3, and that's specific to those 3 leads. And then all other leads, you at minimum require 1 millimeter or greater than 1 millimeter elevation in all the other leads. All right. So when you're looking at those leads, of course, at least 2 of those leads need to be contiguous leads, numerical or anatomical. So numerical meaning they follow each other, anatomical being the same location of the area that is being that you're seeing the ST elevation in. So 2 leads in septals, V1, V2, those are anatomical, so they would follow each other. V2, V3, V4, sorry, are anterior leads. And again, those are both anatomical. Numerically, though, you can have V2 and V3, or those are both numerical, 2 different areas of the heart. However, they follow each other sequentially. That would also be presumptive as a ST elevation, MI. When it comes to limb placements, as we've discussed in the past as well, a reminder that particularly for the ZOL, and even I believe for the light pack for that matter, when it comes to doing a 12 lead, the preferred location for the limb leads, of course, are on the limbs. So as much as possible, you're going to want to place the limb leads along both arms and both legs, and in conjunction with the chest leads to perform your 12 lead. So whenever that is possible. If you're unable to perform or apply those leads to the limbs for reasons such as fractures, amputations, or you're getting a lot of artifact for that matter, then you may move them and put them onto the torso. When doing so, though, it's very important that you document on your EPCR that the 12 leads, the limb leads were actually placed on the torso, and also on a printed copy. If you were to hand that over to an ED, then you note that the limb leads were placed on actually the torso. There was a change in there, so as it may alter the way the 12 lead presents itself. Ideally, those are the changes you're going to want to do when you do a torso. It's also important to know that if you have one amputation of one limb, then ideally you may want to move all the limbs to the torso, so that way keep it consistent so you don't have a varying view when it comes to 12 lead interpretation. Lead validation. So when we're looking at 12 lead, before we even start kind of interpreting our 12 lead views, one of the validation keys that you guys we have taught you guys, and it's still practiced today, it's a good idea to look at lead 1 and AVR. These are your limb leads again. Lead 1 should be a positive deflection, and AVR should be a negative deflection typically. This would indicate that your limb leads are in the right location, and particularly the limb leads that are on your left arm and your right arm. If you happen to cross those, you'll see the reverse of that. You'll see where lead 1 will be a downward deflection and AVR would be a positive deflection. And your 12 lead, though, would recognize that there is a limb lead displacement there, and it would be noted on your 12 lead notes. So the next few slides, we'll go over a couple of practice 12 lead ECGs. So looking at this 12 lead, and a lot of you probably have developed now your own method of how to interpret your 12 lead. Method I like to use is kind of like a systemic approach. And it's important to kind of follow that same approach every time you do a 12 lead, so that way you're consistent and then you're not missing any interpretation there, or you're not missing any value along the way. As if you kind of jump into like the obvious ST elevation or anything that kind of stands out in your 12th. You may miss other precipitating factors or mimics for that matter, and which would kind of contradict your validation or your interpretation for that matter. So if we look at this 12 lead here, and if we walk through it all together, I'll look at particularly in my method of looking at a 12 lead, I'll look at lead 1 and AVR, as we just mentioned, for validation. So lead 1 looks as a positive deflection and AVR has a negative deflection, so I know my limb leads are in correct locations. Then I would look at 2, 3, and AVF. So leads 2, 3, and AVF, if we all remember, leads 2, 3, and AVF are your inferior leads. So this is represented by one cable that is attached to your left leg, your low left limb. It is one cable, however, it's represented with 3 leads. So looking at leads 2, 3, and AVF, I'm looking, of course, for elevation and or depression. So I don't see any elevation in leads 2, I see depression in leads 3, and I see depression in AVF as well. Now moving forward, I would move over to on the right side, which now I would look at leads V1 and V2. V1 and V2 are your septal leads. So the septal leads are, if you remember, they are located, and when you place them on the patient's chest, V1 will go fourth intercostal space to the right of the sternum, and V2, same fourth intercostal space to the left. And this one has a septal lead. Looking at leads V1 and V2, it appears that there is some sort of depression happening there. Next, I would look at V3 and V4. And V3, V4 are both anterior leads. So important to note is, if you remember as I mentioned earlier, when you're looking for elevation, so the column where V1, V2, V3, that column specifically requires 2 millimeters of elevation if you're going to call the STEMI, and everything else is to 1 millimeter. But the importance to note in the anterior leads is that V3 and V4 are both anterior leads. However, V3 requires 2 millimeters elevation and V4 only requires 1 millimeter elevation. So it's important to note that there's a difference in measurement there when you are looking to interpret an anterior STEMI at all. So going back to V3, V3 has some depression that is noted. And if I look at V4, I got a kind of like a hyperacute T wave. It almost looks like there's elevation, but it actually, if I was to measure the J point at 0.4 seconds, it's very hard to determine at this, looking at that point where I'm standing, and if you were to measure it closer, it looks more or less like there is no elevation at all. It's kind of deceiving, however, there would be considered no elevation there. However, moving forward, if I look at V5 and V6, just going back to V3 and V4 lead placements, of course. When it comes to lead placements of that, we typically would put lead V4. V4 would go left mid-clavicular fifth intercostal space, and V3 would go in between V4 and V2. Now moving to V5 and V6. V5 and V6 are located on fifth intercostal space. You typically would place V6 first, mid-axillary line, and then V5 would go in between V4 and V6. Looking at V5 and V6, I can see that there's some elevation noted. I feel like at the J point and then the 0.4 seconds to the right of that, and you can look at the isoelectric line. You can see that there's elevation noted in V5 and V6. And we only require 1 millimeter there. So moving on to, by the way, V5 and V6 would be a low lateral view. So the lateral views are two different views. You got lateral views, lower lateral views would be the V5, V6 right to the chest. And then your high lateral view would be your lead 1 and AVL. Lead 1 and AVL are the next leads over. That will be represented by your cable that you put on your left arm. Is one cable that applies there, but essentially there's 2 leads in there as well, and has a high lateral view. Looking at lead 1 and AVL, we can see that there's definitely elevation there that's more significant than actually V5 and V6. So looking at lead 1 and AVL, this appears to be a lateral STEMI at this point in time. So your last lead to review would be your AVR STEMI at this point in time. You can see some we can see some depression, depression in the AVR as well. So that would be the complete view of your 12 lead. Now we put this all together and you make your interpretation, And it's always a good idea to make your own interpretation as opposed to looking at the machine's interpretation first. As I've mentioned to a lot of you, it's always a good idea to make your own interpretation and not look at the machine's interpretation first, as they may offer a bias, as you may look at if you see words such as STEMI or possible infarct, it may influence you to believe that there's probably something along those lines there where there may not be something there. It may be, in fact, a mimic. That's why it's always important to actually have a paramedic interpret themselves individually versus a machine interpretation. And that's also supported in your companion document of the LSPCS companion document as well. So if I review this whole interpretation piece of this 12 lead, I would determine this to be in my procedures. Actually, I would document the 12 lead procedure code, and then in the results section, I would document STEMI. It's very important to include that, your findings. So what did I find? So is it STEMI positive? STEMI, yes, STEMI positive. Where? This is a lateral STEMI that we can see here. Definitely high lateral that we can see, but I would also include low lateral as well. So you can see there's some elevation of V5, V6. Regardless of either of those, or the high lateral is evidently present. And we also have some reciprocal changes in our inferior leads as well. So when it comes to actually interpretation in your 12 lead findings in your EPCR, you would document that you found your 12 lead procedure code. Your results section would be a STEMI positive and would be lateral. That's what we'd be definitely looking for as far as documentation goes. Of course, at this point in time, the next procedure line, we should also see STEMI alert. So no matter where you're working, even if you don't have a cath lab, a STEMI alert is still valid and is still appropriate to apply and recognize, and especially advise into your local hospital. There's a lot of value for pre-alerting them, so that way things can get underway as far as possibly looking at moving patients around, having a patient ready, calling in a physician, especially if you're working in a small rural area. And of course here in Sudbury, this will be a STEMI bypass. And they would follow the local protocol for that. So here's our next 12 lead review. So to practice again, so we'll go over the same steps just to kind of get into a same rhythm and for consistency as well. So the next slide we can see will validate the 12 lead or lead placements for sure, or limb lead placements. So lead 1 is upright, AVR is downward deflection. So again, our limb leads are in proper location. So then I would proceed to look down at leads 2, 3 in AVF. And 2, 3 in AVF again are inferior leads. And looking at 2, 3 in AVF, we can see some obvious ST elevation present. All right, so now I'll continue on. I can already tell that we have identified a STEMI here, but we'll look at the same 12 lead here. I won't stop here. I want to know if there's anything else that's located anywhere else as well. Looking at V1, V2 are septal leads. So looking at V1, V2, we have some reciprocal change that we can see. We have some ischemia, or we can see some depression along the way that we can see that. V3, V4 are anterior leads. A little depression noted in V3. V4, nothing really substantial noted there. Looking at V5, V6 here, we can see some elevation again. We require only 1 millimeter here, and we can definitely see that in V5, V6, which is now a low lateral. That would be a low lateral view. Now moving over to the left side for lead 1 and AVL. Lead 1 and AVL, nothing so much in lead 1 present. AVL, maybe some slight depression, not a whole lot, but that's irregardless. And then AVR, we got some depression as well. So to sum this up again, when we do our documentation, we have our 12 lead procedure code, and then the results section will include STEMI, STEMI positive, and the location of the STEMI. Here we can see this is in an inferior lateral STEMI. So we have 2 locations that are affected. The inferior leads and our low lateral leads are affected. And then of course there's reciprocal change. So STEMI positive, inferior lateral STEMI. Then of course next procedure, STEMI alert. Also important to note that as far as treatment goes, that when you see a STEMI positive patient, we want to have the STEMI alert This should precipitate you to transport this patient priority for CTAS 1 with a pre-alert, of course. ASA at the very least, it needs to be administered when possible. And then nitro consideration, as we'll get into the 15 lead and V4R a little bit later on, just to review that, when to apply that and when to give nitro. If they are nitro, if they're able to get nitro, then it would be when a STEMI positive patient, it will be a max dose of 3. And if they're not STEMI, then it can go up to 6 doses. Also remember to apply or have ready the defib pads. Research is showing that having the defib pads on, particularly the patient as per the BLS standards as well, is preferable, although it is recognized that obviously some patients may not be will be a little bit anxious about actually applying the pads as they, given the situation at hand, and it may add to their anxiety, into their stress level as well. So, and they may not be compliant with it. So, if that is the case, at the very least, it is important to at least have the pads ready or out and available. And the important thing is also to not have them connected. You just don't want the added noise and or added anxiety from the machine chirping at you with different parts of messages. All right, so have them ready. If not, have them on the patient. Looking at a next 12 lead here. So let's look for interpretation again. So let's validate first. Lead 1 is upright. So validate AVR downward deflection. So again, our limb leads are in correct position. So then we'll look at 2, 3 in AVF. 2, 3 in AVF are again our inferior leads. Looking at 2, 3 in AVF, we can see some obvious elevation in all 3 leads. And as I mentioned earlier, we need at least 2 contiguous leads looking at this. In the inferior leads, there are 3 leads that comprise the inferior leads. We typically only need 2, but in this particular case, you can see all 3 leads are actually elevated. Moving on to V1 and V2. V1, there's nothing really showing in V1. V2, we have some depression noted. V3, there's nothing noted there. V4, we have a little bit of depression that's noted as well. Moving on to V3, V4 are both anterior leads. Again, just a reminder, V5, V6 are your low lateral leads. Looking at V5, V6, nothing really showing in those leads. Looking at our high lateral leads now will be lead 1 and AVL. Lead 1 and AVL are showing both depression here, which would be reciprocal changes to our inferior MI that we're seeing. And then AVR has an inverted T, which could be signs of ischemia as well. So again, when we're looking at this and doing our interpretation, so our interpretation and our procedure codes in the PCR, we'll have the 12-lead procedure code. In the results section, we'll have STEMI or STEMI positive, and then we'll have the location of the MI. In this case, it's just an inferior STEMI with reciprocal change. This patient should be proceeded priority 4, CTAS 1, to your local facility with a STEMI alert. ASA should be administered as much as possible, and then defib pads should be on the patient or have them ready, and then of course consideration for nitro depending on whether you do a 15 lead or not, which we'll discuss further. The next 12 lead slide we have is a normal sinus. Oh, sorry, I was giving away the answer as it just popped up already. Well, that was the answer. Sorry, I didn't move on. My apologies. The next slide here. So lead 1 upright. AVR is also upright on this particular one, but essentially as long as lead 1 is actually upright, it will validate that the lead placement are also in proper position. Looking at leads 2 and 3 in AVF, so our inferior leads, we have nothing. We have a little bit of depression noted, but there's no elevation noted in your inferior leads. Looking at V1, V2, V3, V4, V5, we can see elevation along the way. V1, V2, both septal leads, elevation present. V3, V4, anterior leads, elevation present. V5, V6, low lateral leads. V5 has some elevation present. V6, not so much. We also look at lead 1 and AVL, your high lateral leads, and we have some elevation presenting there as well. And we have inverted T's in our AVR STEMI, not AVR STEMI, I apologize, inverted T's in AVR with signs of ischemia there. So overall, what do we have here? We have a extensive anterior STEMI. Extensive STEMI, global MI, there's multiple terms that could be used for this. It could be even broken down into where the locations are, so septal anterior, lateral STEMI. As you can see, there's multiple locations here where this MI is actually showing. So again, going back to procedure codes, you would have your 12 lead, your procedure code, your results section, again, would be STEMI positive. Then you can use the term extensive STEMI, extensive anterior STEMI, septal anterior lateral STEMI, is just at multiple locations. And again, procedure treatment for this, of course, is ASA as quickly as possible. Nitro dependent, of course, based on whether you require or not. We'll review that a little bit later on. And priority 4, CTAS 1, STEMI alert, and monitor your patient. VFib pads, of course, if I didn't mention that as well. All right, so the next slides now, we will discuss a little bit of a quick review of AVR STEMI. AVR STEMI elevation. So we've been discussing this for a little while now. And AVR STEMI, although if you remember from our very first slide in the presentation, we talked about common occurrence of where the occlusions typically occur. If you remember the ranking, AVR STEMI kind of fell in the 4th line, which was kind of midway in the pack. So as I mentioned, is not as common, but not uncommon either. So AVR STEMI, which may be difficult most oftentimes to identify, but which is important. That's why we kind of review kind of the clinical findings for it, so that way you as a paramedic are aware of some of these potential changes. So classic findings for AVR STEMI are widespread ST depression, most prominent in leads 1, 2, and V4, V5, V6. ST elevation in AVR greater than 1 millimeter, and ST elevation in AVR that is greater and equal to at least V1. Has to be greater or equal to V1. So we'll show that in the next slide. Just to give you some causes of AVR STEMI elevation, so why you might see some AVR elevation and ST elevation. So proximal left anterior descending artery LAD occlusion, so like we're talking about, so left main coronary occlusion. Severe triple vessel disease can also show ST elevation in AVR, and diffuse subendocardial ischemia as well. So looking at the classic finding of AVR ST elevation, MI, so as I mentioned, there's 3 basic criteria that you're looking for. So AVR, of course, needs to be elevated. And if you look at the AVR leads, in this particular case, AVR is actually elevation. There's elevation present. It is greater than 1 millimeter, so that's required. So another requirement is that it needs to be, the elevation in AVR needs to be greater than V1, if there's any elevation in V1 present. So if we look at this particular slide here, or this 12 lead, I should say, V1 has no elevation in it. So therefore, AVR is actually bigger than AVR than V1 lead. Then the other finding, the other classic finding to that for the AVR STEMI elevation identification is there needs to be more or less widespread depression throughout the 12 lead. So if you look at leads 1, leads 2, leads V4, V5, V6, they're all depressed, which is all the ischemia that's occurring basically along the way as we got an occlusion here. So this would be representative of an occlusion of the left main stem coronary artery, which, as you know, is a high main stem occlusion, which oftentimes is referred to as the widowmaker. So, which blocks off a lot of the blood flow to 2/3 of the heart. So, if you're able to identify this STEMI, things to remember is, of course, typically these patients that most of our paramedics have encountered an AVR STEMI, and they're not as frequent. But those that were identified as an AVR STEMI actually did not do well. and as you can imagine. So identification, if identified, then definitely that's the first step to reperfusion for this patient, because essentially time is of essence for these patients. Oftentimes they will not present very well, and if you're typically do not see it, oftentimes in these patients, you may actually find them, and then they might go in cardiac arrest quite quickly. So you do want to prepare yourself. That's why the application of the leaflet pads to all STEMI patients, of course, because there's always a risk of them, the patient going into a cardiac arrest, and so you want to be prepared so you're not fumbling or trying to find leaflet pads when you absolutely need them. And as I alluded to earlier, studies have shown that having the leaflet pads earlier, though, can make a huge difference in return to spontaneous circulation on these patients as they require quick electricity. So some of the requirements, again, just EVR elevation greater than 1 millimeter. Needs to be elevation needs to be greater than V1 if there's any elevation present at all, and there needs to be widespread depression. Okay, but also keep in mind though that the patient should be symptomatic, and they typically would be. So now let's move on to a little bit of the STEMI mimics. So upon our review last fall, we did review some 12 leads with everybody, although we didn't touch much on the STEMI mimics. So this time around, we thought we would include some of those mimics out there. So some of the mimics, by definition, so if you can see those bullet points there, they kind of talk about what a STEMI mimic is, and I think a lot of paramedics understand the term now. It just basically, if you were to define it, it's kind of referred to as an imitator, a mimicker, or a masker, something that can either hide or mimic ECG consistent pattern with ACS. So if it can mimic ST elevation or mimic ST depression or some signs of ischemia, which are inverted T waves or sign of depression again, or hyperacute T waves, then any of those factors can be determined as anything can be determined as a mimic. So that's by definition what they use. Now, some of the mimics that we've talked about over the years or the following, so we've used obviously these slides quite a bit, and these are a lot of the common ones that we like to talk about, and then because a lot of ones that you'll probably commonly see. There are definitely more out there. There are different mimics, probably some rare congenital defects as well that could have some impact on mimics as well. You could also find some different explanation and also some other videos on mimics and other presentations from previous educators along the way. We have had some great recordings from Darlene Hutton, I believe her name was, yes. In the last couple of years. And then you can find those videos on the Paramedic portal at any time for your review. So apart from this recording, there are other videos that you could use as referencing, and of course you may always search out on the Google world. There's essentially tons of information available to you guys when it comes to mimics if you ever needed to refresh your memories or review anything. So looking at the list of mimics that we have here from A, B, C, D, E, F, G, the ones mimics there are mimics in there that are kind of that'll mimic ST depression, which is kind of like ischemia. And those particular ones, it's always nice to know, but at the same time, I feel like most paramedics are more concerned with the ones that mimic ST elevation, because those are the ones that will mimic the fact of whether you're going to call a STEMI or not, and particularly those who are working in the SEBR area where you're bringing someone to the cath lab. You want to be cognizant of the fact that you want to bring actual patients that require reperfusion versus those that they're showing signs of mimic versus an actual STEMI. So, and looking at this list, we're only going to cover in these particular slides, I think 4 of those indications. So 4 of those are mimickers, which are probably the most common ones that you would see in a cardiac patient. So we'll get to that. So the first most common one are bundle branch blocks, and I think over the years, as we've been presenting 12 leads to everybody, the introduction to 12 leads in the last 4 or 5 years now, I believe, we've been discussing bundle branch blocks over a period of time. I think most paramedics are now understanding or are doing their understanding that how to determine bundle branch blocks, which is a large component of actually ruling out a mimic. But again, those who are struggling still, then hopefully this will review, because the more often you review it and the often you kind of review materials, you'll gain a little bit more information, or you'll gain a new knowledge, and you can be able to apply to your practice, and then hopefully it will give you that more confidence when you're doing 12 leads and you're trying to do your interpretations. So just reviewing bundle branch blocks. So you're a blocker left or right of the bundle branch. So you can see your bundle branch comes down. You're in your percutaneous fibers, and it down your septal wall basically, and then connect to your percutaneous fibers, and that's what contracts your ventricles. So the pathway that comes down your septal wall and that conducts the percutaneous fibers, is it's a conduction system that's a functional synthesium. It's a basic rhythm that basically functions together. So when the contractions come together, they both contract at the same time. But when you have a block, though, along the way, what happens is that the ventricles come out of sync. So one will fire, the other one will still often fire, but there will be a delay in there, a delayed reaction to it, because there is a block that's occurring. So what can cause these blocks? Well, biggest cause, though, oftentimes is an actual MI. A previous MI, occurring MI, is one of the reasons that people may develop a bundle branch block. Acute ischemia, of course, previous MI, and angina as well. So it could be some congenital defects as well, and then there could be some hypertension or degenerative heart disease as well. So a lot of people do have bundle branch blocks, and most people can function with them, but of course there may be some limitations to that depending on the damage to the heart as well. So unaffected bundle branch blocks, they polarize normally, as I mentioned. So if the conduction system works very well, it'll go down the conduction system normally, and it'll fire or depolarize, and both ventricles contract at the same time. And those that are diseased, or those that have a block, the impulse goes to the ventricles will be a lot slower, and it won't deliver or be a huge delay. It takes longer to depolarize in this fashion, so the QRS is wide as a result. So when it does fire, if there is a block, as I mentioned, there will be a delay to that. And when it does fire, because of this delay, then the QRS complex will appear as a widened complex, because now as one ventricle is contracting, the other one has not contracted yet. And it's going to be appearing very distorted or very wide. So bundle branch blocks itself. So as I mentioned, it's a mimicker, a masker. So they can produce ST elevation, ST depression, tall T waves, inverted T waves, YQRS, or they may hide it in ST elevation, depression, tall T waves, inverted T waves, and YQRS. So again, they can mimic, and anything that mimics or hides ACS signs and symptoms, or signs and symptoms, as I mentioned, is considered a mimicker, and bundle branches may do that. So things to remember, though. New or presumably new, particularly left bundle branch blocks, though. These patients here, if you're able to identify that, these patients actually do require reperfusion therapy. They are a candidate for reperfusion therapy. The kicker, if you will, or the questions that need to be had, though, is how do you know? Oftentimes, though, it's hard to determine. It may be that it's been pre-existing already. So how would you determine whether it's a new one or versus an old one? So the clinical significance of a left bundle branch block. So just to put this in perspective, so a left bundle branch block caused by acute myocardial infarction, 60 to 70% associated with pump failure, and then 40 to 60% mortality without reperfusion. So it's quite significant. So especially in a new left bundle branch block present. So if you're able to identify that there's a new one present, we definitely want to call a STEMI on these ones, because essentially that could be the main cause of why you're seeing a left bundle branch block. So critical to reperfuse patients with new or presumably new left bundle branch block produced by ACS, which is acute coronary syndrome. It could be hard to identify on ECG when a bundle branch block is present, so how do we know? So as we mentioned before. So the solution, of course, is new or presumably new left bundle branch block is an indication for reperfusion therapy. So try to be cognizant of whether the presentation or not, if they have a history of it or not, which again may be hard. A lot of patients may not know they have bundle branch block disease, or they may have previous bundle branch blocks. So in the presence of prior history, any cardiac history or whatnot, somebody without a previous history and or cardiac meds, and then you're not seeing a bundle branch block, and all of a sudden it appears in an MI, that should be kind of construed as a actually new occurrence, which should precipitate the indication, or should prompt you to think about perhaps this is a brand new left bundle branch block caused by a possible MI, which should need reperfusion. So how do we identify a bundle branch block? So it's supraventricular in origin, because it's coming from the ventricles. So a normal conduction system for a QRS complex from the ventricles should be less than 0.12 seconds. But as we mentioned before, when there's a delay, then that will increase the timeline. So that will increase the width of the QRS complex. So it's by definition basically greater than anything than 0.12 seconds, or 120 milliseconds when you're looking at your ECG paper. So when you're looking at the two strips analysis there you have from your 12 leads on the two examples that you're showing, the one on the left shows a QRS duration of 104 milliseconds, which is under the 120 milliseconds. So that would represent that the conduction system to the ventricles in this particular case is normal. So there's no block present there. But if you look at the one on the right, the QRS duration on this particular one says 136 milliseconds. So that one will suggest that the ventricle, there's some sort of delay going down to the ventricles, leading to this bigger measurement. So that's why you're seeing 136 milliseconds. So the unique pattern when you're looking at the 12 lead itself is that your ventricles are going to be out of sync, so it's wide. Looking at lead one will be able to help you determine whether you're looking at a left or right bundle branch block. So that will help you give you the location of which side of the bundle branch is it occurring, or which one is probably occluded, or there's a block of some sort. When you hear the term bunny ears or classic bunny ears, it usually refers to the right bundle branch blocks. As you can see, there's two deflections happening there. And the left bundle branch, though, will just be usually a QS complex, so a big, wide, downward deflection seen in V1, where if it's a right bundle, then you have a double deflection, aka the bunny ears. Diagnosing a bundle branch block. I find the simplest way to diagnose the bundle branch block is basically doing this turn signal method that a lot of paramedics probably already heard of. The way you do that is you look at V1, as I mentioned, because V1 is important, because if you remember the location of V1, V1 is looking at the septal wall, and that's where the occlusions usually happen when the bundle branch blocks. That's what the reference point is. So looking at these pictures over here, you can see that they talk about circle the J point. So look at the deflection and see what angle is deflection going. Is it going upwards or going down? And if you look at the slide that you see with the diagram that you're seeing, the deflection here is going down. But you look at you find that J point, and then you circle it. And from the J point, then you move basically backwards. So you kind of see where the deflection is going. So basically go to the left. Typically when we use ST elevation, when we're trying to measure ST elevation, we typically go to the right and then start measuring. But in this particular case, for diagnosing a bundle branch block, you're just actually going to go to the left. So move to the left. So go basically backwards, if you will. And then whatever the angle of that deflection is going will give you an idea whether that's a left or right. And if you see the first step one, actually it's showing and it's giving you an angle that's going down, well, that would be a left bundle branch block. And this is how you apply the turn signal method. So the turn signal method applies to, if you can imagine yourself driving a vehicle or motorized vehicle, a car, and as you want to make a left-hand turn, you would turn your signal light down to activate the left signal. So when you turn that down, you're making a signal to turn left. Same principle kind of idea here. You look at V1, you circle the J point, you work yourself backwards, you can tell that the deflection is actually going down. So this will be considered a left bundle branch block. If you had the reverse happened, if you look at the second one underneath, if I find the J point and then I can see the deflection, I circle the J point, and if I see the deflection going up, the first deflection is going right after the J point, is going up in this particular case. Although there's a downward deflection, as we mentioned, but the first deflection is actually going up. So this is representative of a right bundle branch block because it has a double deflection, if you will. So again, the turn signal method, now here in this particular case, we want to go up. If you're driving a car, well, that would be representative of a right bundle branch block. I find this to be the easiest method to determine a right and left bundle branch block. This, of course, is in conjunction with the fact that you measured your QRS complex and it's bigger than 120 milliseconds. Alternate methods to measure a left bundle branch block and a right bundle branch block are the following. Some probably veteran paramedics probably have heard of this method before. It's probably beneficial for some paramedics to learn it this way. Whatever works for you to identify them, either one is acceptable. But an alternate method here for determining a left bundle branch block is to look first at lead 1. And if you can tell that lead 1 is wide, there's a good chance it's left bundle branch block. You have to confirm that as well, as that you look at V1 as well to see if that is wide and should have a negative deflection. And then by looking at V6 as well, it should be wide. So lead 1 and V6 and a downward deflection in V1 would indicate a left bundle branch block. Okay, so there's that example I just mentioned. So it's got to be wide. QRS duration is greater than 136. Lead 1 is wide. V1 is downward, and then V6 is wide. So this would be considered a left bundle branch block. Same principle to determine the right bundle branch block in this method. So look at lead 1. This time lead 1 should be narrow. V1 in this particular case will be wide but upright, and then V6 will also be narrow. So looking at this example over here, the QRS duration again is greater than 120, so we can see at 140. 144, I should say. Lead 1 here in this particular case is narrow. V1 is positive, but it is wide. And V6 is narrow. So there's your alternate method. But again, whatever works for you to determine whether it's a right or left bundle branch block, both these methods will work. But my preference simply is determining the turn signal method and determining that the QRS duration. So we have a couple of practice bundle branch blocks here. So let's take a look at the first one. So again, I will just apply the turn signal method because again, that is what I'm most comfortable with. So the question here is asking, is this a right bundle branch block or a left bundle branch block? So looking at the 12 lead itself, if I'm looking for a bundle branch block specifically, well, the easiest thing to do is look at the QRS duration. And by looking at the QRS duration, I can see right away that I got a duration of 144 milliseconds. That is greater than 120 milliseconds required. So I know there's some sort of block there some sort of way. Now, if I look particularly at lead V1, I can see that there's a downward deflection. So if I apply the turn signal method, and I'm going to move my turn signal down, or my stick down, that I'm going to turn left. So this will imply that this is a left bundle branch block. So it's as simple as that. Vice versa, if I was to look at the second bundle branch block here, so again, do I determine, is there a bundle branch block? Well, if I look at the QRS duration, it says 186 milliseconds. So I can tell right away that there is a bundle branch block. It is greater than 120 milliseconds. So I know there's a block in there somewhere. If I look at V1 particularly, and in this particular case, I find the J point, I can see the deflection is actually going up. So if I apply the turn signal method, and I want to move my turn signal up, that means I'm going to be turning right. So essentially, and this means that my V1 that I'm seeing there, this would be represented by a right bundle branch block. So I got a Y QRS complex, and it's an upright deflection in V1. That's a right bundle branch block. So that is how you determine a right and left bundle branch block. Now moving on to another mimic. So bundle branch block being the most common one as a mimicker. A second one most common that you would see would be left ventricular hypertrophy, LVH for short. So LVH, I think a lot of paramedics are understanding this term nowadays. So LVH is an increase in pressure or volume. It's found in mitral or aortic stenosis, cardiomyopathy, hypertension, and ischemic heart disease. Experts disagree on ECG accuracy, so I'm reading here obviously of the bullets. Nonetheless, the criteria are proven. Definitive diagnosis, though, is an echocardiogram. So LVH, when you have LVH, the common cause is basically your heart being under pressure for long periods of time. And those are the examples that are shown there. So it just makes a large left ventricle. So the muscles, over a period of time, the muscle is being pushed to its limit, so it is contracting, so under pressure all the time, so it actually grows as you develop your muscles. If you do exercises commonly or you work out very much with heavy weights, eventually your muscle will grow. It's kind of the same instances in this particular case. However, the heart now is working really hard, so it's developed a bigger muscle. Doesn't necessarily mean that it's actually better for the patient, essentially, because essentially it's got a bigger left ventricle. It just means now it takes a longer time to depolarize. The muscle's so big, and it's got more muscle in it. So volume doesn't change-wise, but essentially the muscle has a hard time to depolarize. So seeing some of this criteria that we're going to use to determine whether LVH is present, you can see that the last bullet, though, says definitive diagnosis, though, is through an echo. So some people may not even know that they have this, but some of these criteria will probably prompt to have an echocardiogram done to see if, in fact, that is indeed the case of why we're seeing these represented on 12 leads. So LVH voltage criteria, rule of 35. So some of you guys may remember the rule of 35 or that term. However, it can be complicated when you're trying to apply it because there are a couple of steps that need to require to apply the rule of 35. So we're just going to review those. So how do you do that? Well, what you're going to do is to determine whether there's LVH present. You're first going to look to see if there's a total of 35 millimeters of voltage, and the patient is older than 35 years old. Okay, so those are the criteria that you need. So the patient needs to be older than 35, and then you want to see if there's a lot of measurement or if it's really deep and high. You're seeing some waveforms to determine whether you can apply this LVH criteria or this mimicker. So the way you're going to measure this is you're going to be looking at V1 and V2 or V5 and V6. So V1 and V2, you're going to measure the deepest S wave. And so either one of them, it's not both of them. You're gonna look at the S wave. You're gonna measure the deepest S wave in either V1 or V2, and then you're gonna measure the tallest R wave in either V5 or V6. So again, it's not the combination of V5 and V6 and V1 and V2. It's one of the two. Okay, so the deepest S wave in V1 or V2, or the tallest R wave in V5 or V6. And then you're also going to look for the strain pattern. The strain pattern is usually a common characteristic that's usually associated with LVH, so it's typically will kind of validate that it's present. So you oftentimes will see it in the presence of LVH. Then the other kicker to this, though, is that you may also see LVH also may be present, though, in just AVL itself. So just in that particular lateral lead itself, if that one is tall, greater than 11 millimeters, that can also constitute as LVH as well. So we'll get to the examples here, which is, I think, is a better way to show the application of this rule. So in looking at this particular slide, if we're seeing, the one thing that stands out, though, of course, as you can see, is that you can see these big, long depolarizations. And if I look at V1 and V2, you can see they're almost touching each other. And that's usually kind of an obvious sign that possibly LVH is present. And so, again, you're trying to, as a paramedic, you're trying to figure out what kind of, how to rule out some mimickers. And this one, I think, stands out when it's obvious. So hopefully paramedics can remember in future practice. So if I look at V1 and V2, the depolarization is quite long. If I look at V5 and V6, those R waves are pretty tall. So what we're going to do is we're going to measure either one of them, V1 or V2. We're going to measure the tallest one. So if I look at V1 and V2, V2 actually seems taller than V1. So I'm going to measure that one first. And you're going to measure from the J point all the way to the tip of that deflection down. So if I measure that, and simply counting, you're going to count every little box. Every box is worth 1 millimeter, as we remember, because that's how we measure ST elevation as well. So if we look at the deflection down here in V2, the simple way to count that as well is look at the big boxes, because each big box has 5 millimeters in it. So that makes it easier to count especially when you're trying to count 35 and more. So if I go down the V2, I can see that there's 1, 2, 3, 4 boxes at least. So that's 20 millimeters. And then if I look up by the J point, there's probably another 2, 3, probably at least 3 millimeters there. And then the tip at the bottom is probably another 2 or 4. So there's probably about 25 millimeters already in V2. So like we're well above, we're on our way to like meeting the 35 millimeters that's required. So now I'm going to take that 25 millimeters at least, and now I'm going to look at V5 and V6 and see which one's taller on those two leads. They look very similar in height, so I'm just going to take V6 for a good measure here, because essentially I got to pick one. And I'm going to add the 25 millimeters that I found in V2 to this V6. So in V6, I can see that there is at least 1, 2, 3 boxes, big boxes there of 5 millimeters. So there's at least 15, if not 17 millimeters there. So if I add that to the 25 already, so we're beyond the 35 millimeters that's required. So as long as to apply this LVH rule, this patient needs to be greater than 35 years old. And the fact that we're over 35 millimeters in V2 and in V6 together, we can constitute that this is possibly LVH. So again, which would be a mimicker. Also, in reading your 12 lead, your machine diagnosis might also indicate that you might see a messaging from your 12 lead indicating that to check voltage criteria, meaning that it's identifying that it's seeing big depressions or not big S waves or big R waves that are depolarizing really long, which again would imply that it's possibly thinking that there could be left ventricular hypertrophy in this particular 12 lead reading. So this is an example of rule of 35 applied to the V1, V2, or V5, V6 leads. Now another example, again, as you can see in this one here, that's also LVH. If you look at the V1 and V2, as we're thinking about LVH in this particular one, and then V5, V6, you can now see in these ones here, now it's not as obvious as the last 12 lead that we just saw, but LVH is present here. It's just not seen in V1, V2, V5, V6 leads. Where it's obvious here, it's seen in the AVL. AVL lead here is another way to determine whether there's LVH present, which also kind of applies to the same rule of 35. In this particular case, though, AVL is greater than 11 millimeters. So this lateral lead here in AVL is, if you were to count it, it is more than, it's kind of, just more than 11, so probably like 12, 13 millimeters on itself. It's that tall. So that, in the conjunction of the fact that if the patient is greater than 35 years old, this also will constitute LVH. All right, so something to remember. A lot of people remember the V1, V2, V5, V6 combination, but a lot of people tend to forget that AVL itself is also a way to measure LVH. Another mimic rhythm that is probably commonly seen out in the real world, or paramedics may come across, is a paced rhythm. Now, paced rhythms are also mimickers, considered mimickers, of course, because their obvious appearances. They are wide and it'll probably create some elevation as well, presenting elevation. So in this particular case, we have a ventricular rhythm here that's being paced, and you can see that, especially if you look in the inferior leads, it kind of looks a little bit elevated, but it's also wide, and you see that pacer spike just before it. So this is indicative of why this could be a mimicker, because it's undetermined whether it's the pacer that is actually causing the elevation, or in fact, is there an actually underlying and why that's occurring. And it could be difficult to tell. So in this particular case, patients with ventricular pacers typically would have to cause a non-STEMI, and this would be a mimicker for that sense, because essentially you're not able to tell whether this is an actual STEMI or not. Most oftentimes you will have to go with the cause that it's probably the pacer that's acting this way. So therefore it would be a non-STEMI. The last mimicker that we have in these particular slides is early benign repolarization. So early benign repolarization, it's kind of included in the title. I mean, it's benign. Typically, most oftentimes, patients don't know that they have it. Symptoms may not fall in line. So, I mean, essentially, oftentimes this gets missed because essentially it's not really relevant, because essentially it's not relevant to the patient. I mean, they may not be exhibiting symptoms that are requiring you to do a 12 lead. But those that may have some weakness, or may have a syncope episode or whatnot, and then you happen to do a 12 lead, you may stumble across this. So the way to diagnose this, we're going to see is that there's going to be a little notching that's kind of identified in the 12 lead that creates this elevation, which kind of, again, mimics the fact that there could be some ST elevation when in fact it is a mimicker. So early benign repolarization typically, though, are seen in younger adults, and apparently the African American males are typically more prone to having early benign repolarization. What you typically may see out of this is a notched J point, as I mentioned. So you'll see at the end of the QRS complex, you'll see ST elevation, but essentially you're going to see a little hook that kind of identifies a little tug that tugs up on the ST elevation, that pulls it up a little bit and creates that illusion that it's elevated. So you can see in the diagram there that you can see that little notch or the J point, or that little hook that you can see that's kind of pulling up on it, and it's creating a little bit of elevation. You got a concave elevation as well, so you can see that it's kind of like that droopy kind of look. Oftentimes ST elevation are convex, basically, or you got like a kind of a rainbow type thing. They go upwards more or less, not so much downwards. So that's another characteristic that you may want to look at when you're looking at early benign repolarization. Leads 2, 3, AVF, V4, V5, V6, lateral leads. So I mean, you may see them in multiple leads, where you might see these J points or these notching that they're talking about. So again, this is what it looks like. So ST segment and J point creates a fishhook appearance, so you can see kind of like that fishhook if you were to remove that. So it's just a little notch that creates at the end of the QRS complex, making that little lift up. Very good. So that is the end of the early benign repolarization and the mimickers, for that matter. We have a couple slides left. So these are practice slides. So the next few slides, I will allow time for you guys to determine yourselves, and then I'll go over the findings of the 12 lead. So let's take a look at this first 12 lead. Let's try to identify whether this is a STEMI or not. All right, so give you a chance to look whether you guys think it was a STEMI or not. So in this particular one, it is a STEMI, right? So if we go over our steps to determine whether there's a STEMI present or not, so lead 1 is validated, AVR is downward deflection, 2, 3 in AVF. Interior leads don't look like there's any elevation. Leads V1, doesn't appear to be any elevation there, but V2, we do see some elevation. V3, we see some elevation. V4, we see some elevation. Minor elevation in V5 and some in V6. lateral leads, high lateral leads, lead 1 in AVL, not so much, and then nothing in AVR. So we have at least an anterior septal MI that we can see here in these 2, 3 in AVF. Sorry, my apologies, V2, V3, V4. So there's definitely a STEMI there. All right, let's look at the next lead. So this is quite obvious as to what to do here. Can we tell if there's a STEMI here? No, we cannot. This is a bad tracing. So if you're unable to see that, then of course, patient's moving, there's a lot of interference here, then we need to redo a 12 lead. Trying to interpret this would be not useful at all. Essentially, you have too much wandering baseline, so essentially it's not a clear 12 lead. Definitely what you want to do is repeat this 12 lead in this particular case. Here's the next one. All right, so whether we think this is a STEMI or not, is it a STEMI? And the answer here is yes, it is. So again, let's validate. Let's look at our steps. Validate, lead 1 is upright, AVR is downward deflection. 2, 3 in AVF, we have some depression in their inferior leads. V1, V2, we have a little bit of elevation in V1. V2, we can start seeing some elevation there. V3, V4, we're starting to see elevation as well. V5 has some, looks like some elevation. V6, not so much, but we also see it again in our high lateral leads, lead 1 in AVL. And then we have some depression, some depression, sorry, in AVR. So here we have, again, an extensive anterior MI, or anterior septal lateral MI, however you want to call it, global MI, multiple locations. So STEMI is present here. All right, let's look at the next one. All right, so is a STEMI present? Yes or no? And the answer here is yes, it is. So if we look at lead 1 is validated, it's upright, AVR is downward deflection, 2, 3 in AVF is elevated. So we have an inferior STEMI already. Look at V1 and V2, nothing so much. V3, V4, nothing there. V5, V6, nothing that's obvious. Lead 1 and AVL, a little bit of depression there. So what do we have here? We have an inferior STEMI with some reciprocal change. Now, the one thing that's also important to note here is that we're also seeing some interference here. So it looks like some 60 cycle interference is also happening at the same time. So this could be due to the fact that we were getting a lot of radio communication that's probably interfering with this 12 lead or some sort of electrical impulse or something that's happening along the way that you're getting this interference as well. So be mindful of the source. So if you're close to something that is actually generating this interference, you may want to move away or maybe repeat if you couldn't read it. But in this particular case, you can make out the 12 lead. There's just that interference noted in there. All right, so here's the next one. I'll give you time to look at it. Is it a STEMI or is it not? Yes or no? Answer here, yes it is. So if we look at our leads again, so lead 1 validate, AVR is also positive in this particular one, but essentially we know that our limb leads are in place. Lead 1 is also a positive deflection. 2, 3 in AVF, we don't see anything so much there. It's hard to tell whether there's elevation there. It doesn't appear to be that obvious. V1, V2, though, we do some elevations in V1, V2, V3, V4, and questionable in V5 and V6, but that doesn't really matter, though, because it's quite obvious in the anterior septal leads. So, and lead 1 in AVL, nothing so much there, and nothing in AVR. So, or probably a little bit of elevation in AVR, but that's doesn't really matter, to be honest. Essentially, you're seeing it, V1 is actually bigger. So this looks like a septal anterior MY here. So STEMI positive, yes it is. Very good. So this concludes this part of the STEMI review, the 12 lead and STEMI review. Now we're going to discuss a little bit, we're going to review the V4R and 15 lead ECG. So this was brought forward last year in the fall round, so we brought this back again so that way we can review, make sure that all paramedics are comfortable with the application of V4R and 15 lead and when to apply it. So the question again, if you remember, why are we doing it? Well, not stated earlier, your 12 lead that we have currently does not essentially have a complete view. We can see a lot of the area of the hearts, but it does not provide a complete overview of the whole heart. So doing if you're doing a V4R, it's only going to show one side. But if you do a 15 lead, it's a combination of both. You're able to see basically the right side of the heart, and you're also going to see the posterior side of the heart. So it just adds some additional views to the heart, gives you a better picture of understanding of what you're seeing with the patient. Also, the other reason, clinical reasons why we're going to do this as well is also to adhere to the medical standards or medical directives, I should say. In order to give nitros, though, you need a 15 lead, or more specifically V4R, to rule out whether there's any right ventricular involvement prior to giving a nitro administration. So for that part as well, we want to comply with the ministry standards. So those are main reasons why we will be doing a V4R and 15 lead ECG. So jumping into V4R, we're going to be looking at, if you're going to isolate the right ventricle side, very simple to maneuver and figure out how we're going to apply this. The reason we're going to be doing it, the main reason, is for nitro administration. So that is the main purpose of moving the leads from V4 to V4R. The way you would do that is you take V4, which is existing on the left side already from your original 12 lead, and you would simply grab another daisy and then move it to the right side. Same location, so mid-clavicular, right side, 15 intercostal space, then apply that. That is simple there. The only thing that you need to do now is repeat the 12 lead now, because now you move the leads over, so you need to reacquire a 12 lead to get a new interpretation. And once you do that, though, whenever you change the leads, whenever you change your location of the leads where they should be, then it needs to be identified both on the EPCR and also on the paper copy. So that way, if you're handing it off to a physician or any other healthcare care facility, that they're aware that what they're looking at is a modified placement view of the leads. 15 lead ECG encompasses the V4R, so it has the V4R in it as well, but it also has the added addition of V8, V9, so it's giving you two additional views on top of that. So the V8, V9, though, is going to allow you to look at the posterior side of the left ventricle. All right, so it gives you more of a complete look around the whole heart. All right, the way you move the V8, V9, so that would happen by moving. This occurs by moving V5 and V6. You take V5 and V6 off where they're located on the lateral view, so on the fifth intercostal space. You take V5 and V6 and then you move them around to the back and they become V8, V9. V5 goes mid-scapula, fifth intercostal space, so you basically wrap it around the fifth intercostal space to the back side of the left ventricle, and you put that mid-scapular area at the fifth intercostal space, and that becomes V8. And then your V6 will become V9, and that one will be placed in between your spine and V8. So you find your spine, you find the patient's spine, I should say, and then where your location of your V8, you'll put the V9 in between those two spaces. So just some additional information about V4R and 15 leads. So V4R by ministry standard is mandatory. It's mandatory for nitro administration. So in your cardiac ischemic medical directive, you'll see that at the bottom there's a clinical note saying that you must do, actually it says you must do a 15 lead, but more or less specifically look at the V4R component of that, because the V4R component is what is specific to the nitro administration. The 15 lead is an optional at this point, meaning that it's more or less the addition of V8, V9 is optional. It's an added bonus view. However, you may have seen a lot of our PPCs, such as myself, parent practice coordinators, have probably indicated that it's probably beneficial to do a 15 lead. If you're going to move one lead, such as V4R, then it's beneficial to move the additional 2 leads. It shouldn't be added more time. That way you get a complete package of V4R plus V8, V9. So the ideal situation is if you're going to move one, move them all, and then you would get that complete view, including the V4R for that matter. So, and like I mentioned before, the V4R is more specific for the nitro, the V8, V9 though is specific to the posterior end. So if we're talking about V4R specifically, when should you acquire V4R? So it's pretty simple. You're going to do a V4R at minimum if you need to in the presence of an inferior MI. So you can see in this particular slide that leads 2, 3, and AVF are elevated. Now, a couple of disclaimers here. As I mentioned, we need an inferior MI. It doesn't. So an inferior MI, by definition, is 2 contiguous leads that are showing elevation. In this particular case, there's three leads that are elevated. So let's not take this literally. You don't need all 3 leads to be elevated for you to do V4R. If only 2 of those are actually elevated, then that also would require a V4R application. Okay, so 2 of the 3 leads need to be elevated, but it needs to be elevation. Oftentimes, in the last rounds when we talked about this, some still got this confused with depression. Depression and elevation are 2 different things. If 2, 3, and AVF are actually depressed, then a V4R is not required. The only time V4R is required is when 2, 3, and or AVF, so 2 of those 3 leads at least are elevated, not depressed. So when you do a V4R, so when you do move that V4 leads to the right side and you repeat your 12 lead, essentially what you're going to do is you're going to have a second 12 lead. And the original, everything else on your 12 lead should be actually looking the same because essentially this should be repeated right after the original 12 lead that you have. So the second 12 lead, once you do the second 12 lead, basically you're just going to be looking for the changes that you made. So in this particular case, V4R is the new lead, so that's where it's going to be located. So that's what I'm going to want to look at because that's where I'm concerned about whether there's right ventricular involvement on that side or not. And this particular lead, if I'm looking at this 12 lead right here, there's no elevation noted here. So that means there's no right-sided involvement. Therefore, it's more isolated to the left side of the heart. Therefore, this patient can get nitro. And if this patient can get nitro, there'd be a total of 3 nitro sprays. So to determine elevation, V4R, if there is elevation in V4R, it needs to be at least 1 millimeter. That's consistent with all other elevations, STEMIs that we noted previously. Acquire V4R when a patient has an inferior STEMI, as I mentioned, so greater 1 millimeter in 2, 3, or AVF, so or in 2 or 3, or 3 in AVF, so it's a combination or all of them together. V4R can be quickly acquired in the setting of load and go, so it doesn't take a whole long to do that because essentially you're moving 1 lead over in this particular case. But you do need to do this in order to give nitro in the presence of an inferior STEMI. So again, we were talking about the placement, so you take V4, you move it to the right side, fit intercostal space on the clavicular side, and then repeat the 12 lead. Once you do that though, like I mentioned, as I mentioned, you not only do you need to write the subsequent 12 lead acquisition in the form of a V4R, but you also need to change the relabeled on the second printout. So the second printout that you have, you'll need to make sure that it's noted that you have you made a change in that lead presentation. So V4 becomes a V4R, and that will be represented as you can see on the paper there with the markings. Okay. So this will be useful, especially if you're handing it to a healthcare facility. So, as I mentioned, you need to document that your manual interpretation as you do when you do change your 12 leads. The machines do not recognize the fact that there is no other button specific to V4R 15 lead that I know of. So therefore, the machine won't know that you've actually changed the leads around. So that's why it's important for you to manually interpret it on your documentation and on the form itself. Okay. So if there's elevation present in V4R greater than 1 millimeter, that suggests there's a right ventricular MI, and then therefore there would be no nitro. So how do we document this? How do we document V4R and ECG? So you have your 12 lead. You do your original 12 lead. So remember, it's important to do your original 12 lead. Your original 12 lead will have your 12 lead code, procedure code, and then your findings. In your findings, again, as I mentioned, it's very, very important that you document what did you find in your 12 lead. So in this particular case, you can see we have an ECG that says normal, but also notes that there's an inferior STEMI noted. So there's our finding. There's an inferior STEMI, and we need to see that in order for you to move on. So in this particular case, we have an inferior STEMI, so we know that there should be a following 12 lead that follows this, because now you need to know whether you're going to do a V4R or 15 lead for that matter, and whether you're going to be giving nitro. So you can see in this particular case, we have the second 12 lead that appears. And then the remark section there, we can see ECG normal sinus rhythm, but it has the notes of V4R ECG, elevation noted in V4R, nitro withheld. So the comments of the nitro withheld there, that's fine, but it can also be put into a different comment code and a procedure code, meaning that you assessed for nitro and the patient did not meet it. What's not acceptable is do not use the nitro code to note that you didn't give nitro, because that would be a false documentation of it. All you would want to put is some other assessment or a common code saying that you assessed for nitro and the patient did not meet the requirements. But findings the results are very, very important as to what you found. So in this particular case, you got two 12 leads, and that's how they're going to appear. And the second one clearly identifies the V4R ECG. This was a V4R, and there was no elevation noted, there was elevation noted in V4R as it was stated there, and therefore no nitro was applied. So let's practice here. There's a couple of 12 leads with the added V4R. So now if you're looking at specifically the V4R section, because that's been changed, if we look at this one here, is right ventricular MI present, yes or no? So we look at this one in V4R, there's elevation there, yes. So there's elevation in V4R. So this would suggest that the inferior MI that we're seeing on the 12 lead is likely involving the right side. So it's extended to the right side of the ventricle. Therefore, nitro is contraindicated in this particular situation. We don't want to give them nitro, as it could actually worsen the patient, deteriorate the patient, make them hypotensive, or put them in an actually cardiac arrest, as no volume will be circulating, or the volume will be very low in circulating volume. So in this case, no nitro will be given, simply ASA. That is it. If we look at the next 12 lead here, so nitro or no nitro, and they add a question here is there's right ventricular involvement, so therefore no nitro. We can see the V4R, there's elevation there as well, it looks at least greater than 1 millimeter. Therefore, we will withhold nitro and only give ASA to this patient. Here's the next slide. We have V4R. So looking at this V4R, will we give this patient nitro or not? Is there any elevation? So we don't see elevation. It's not evident that there's elevation in this particular one. So therefore, you could give nitro. So it would be more or less indicative that the MI is likely happening on more or less on the left side rather than the right side. Although it says right ventricular MI here, essentially it's not quite obvious that there's elevation there. So essentially, we could give this patient actually nitro to the extent of 3 nitro sprays. All right, moving on to the 15 lead. When should a 15 lead be acquired? So there's kind of 3 situations where a 15 lead would be acquired. So when we reviewed the V4R, there was only basically one situation that was an inferior MI. But for a 15 lead, there's other situations where you might consider a 15 lead. So any patient with an inferior MI, so similar to a V4R, of course. So an inferior patient, we're going to want to do a 15 lead. We're also going to want to do a 15 lead when there's ST depression in V1, V2, V3. Or when there is an inferior STEMI and there's ST depression in V1, V2, V3. So those are, those are the three occurrences where you might want to do a 15 lead, or where you should do a 15 lead if you're going to do a 15 lead. So in the presence of an inferior STEMI, the depression in V1, V2, V3, or both. There's an inferior STEMI and there's depression in V1, V2, V3. Okay? So indication for 15 leads, we can see any inferior MI, but especially if accompanied by ST depression in V1, V2, V3, and or ST depression in V1, V2, V3 on its own in the patient symptomatic with ACS. Okay. So as I mentioned before, the inferior portion of it is more particular to the V4R. The inferior, if there's depression in V1, V2, V3 along with an inferior STEMI, usually that's common presentation for an inferior posterior MI. If you do a 15 lead at that point, you might see elevation in the posterior V8, V9, especially with depression in V1, V2, V3. That's kind of like the reciprocal changes that you're seeing through the posterior end from the front side. So in that particular case, that would be specific to the posterior end. But the V4R would be specific for the nitro on the inferior side as well. So that's why the three would kind of go together. So use when a patient has an inferior STEMI or suspected posterior STEMI, as we talked about before. Can confirm posterior STEMI, usually associated with an inferior MI. So as I mentioned before, usually the two go together. It is possible to get an isolated posterior MI, but usually, if you remember from the first slide that I referenced to the beginning, the commonality of an actual posterior MI are not as common. They're actually even less common than an AVR STEMI, but essentially they still can occur. And without doing a 15 lead, though, you wouldn't be able to see that. So the ability now to do that, you can be able to recognize that, and that will allow you the ability to call a STEMI in times where you wouldn't be able to see it initially, but by doing a 15 lead, you'd be able to pick it up on the second 12 lead that you do. So why do a 15 lead ECG can also suggest that the right ventricular MI, which is larger and more complicated than inferior MI. In the setting of an isolated posterior MI, elevation in V8, V9 has to have greater than 1 millimeter elevation to be considered posterior MI. And then nitro can be administered times 3, as long as there's no V4R involvement or right-sided involvement as well. So elevation in V8, V9, very similar to all other leads, need at least 1 millimeter elevation. And because there's two leads there that require, that you're looking at, that's looking at the same area, the posterior side, you need both of those leads to be elevated 1 millimeter to be considered a posterior MI. So when acquiring a 15 lead, so we've already talked about placement already. So we're going to move, it's a combination of V4R and V8, V9. We're going to move V4R, we're going to move V4 to the right side, so the same location to the right side, fifth intercostal space, right side, midclavicular. That's V4R. And then V8, V9, we're going to take V5, V6, which becomes V8, V9. V5 is going to be placed at fifth intercostal space, mid-scapular. And then V9 is going to be placed between the spine and V8. Once you do that, as mentioned, not only on documentation on your PCR, but also on your paper copy, you will relabel and identify that you moved the leads. And this is a second ECG or a 15 lead for that matter. And these are the changes that were made. So you can see on the paper copy here that they've been V4, V5, V6 have been striked out, and now you see the new changed leads, V4R, V8, V9, and then the new presentation of what you're seeing on the leads. So as I mentioned, there is no 15 lead button on your machines, so therefore you actually have to do another 12 lead. To do so and manually interpret that, so the machine again does not recognize that you moved the leads, so therefore you need to identify that you made the changes. So it should be written on your EPCR and also on the paper copy that you've recorded. So documentation of a 15 lead. So in this particular one, there's a couple steps that need to be required, just because how you need to do this when you document this in your iMedic, or sorry, I should say is your, no, this is your, when you document it on your ePCR, your electronic ePCR. You're going to have your original 12 lead, as you can see in the diagram of the picture. You're going to have your original 12 lead and your original findings. So your ECG, normal sinus rhythm, and then you're going to have your findings. Here in this particular case, we have an inferior STEMI noted. And then you're going to move your leads over to do your 15 lead. And then when you bring over that information, it's going to appear as another 12 lead as it does there, as you can see. Although you change the leads, as I mentioned, there's no 15 lead button, so it comes across as a 12 lead because your machine does not know that you move the leads and you're adding it on. You're just basically, it's still a 12 lead button that you have to press. So in the comments on this particular 12 lead, you would write the comments of, this is a 15 lead, just to identify that you're using this as the second 12 lead here is actual 15 lead, the add-on leads that you added. And then what we're going to ask you to do is to use the actual procedure code that does exist for 15 lead on the next line on your procedures. So the next line should have the procedure code, 15 lead acquisition, and then your results there. This is where you're going to post your results, so of your 15 lead. So you can see the notes, ST elevation present in V8, V9, no elevation in V4R. And that's how it should be documented. It's a little trickier, however, but that's just a limitation of what you can do with your electronic documentation records. It just will, and your device for that matter, because it doesn't recognize automatically that you change this into a 15 lead. If it did, it would be a lot easier, but it does not do it that way. So these are the steps that's required. So your original 12 lead, and then your second 12 lead with the changes, and then actually the actual procedure code, because there is a 15 lead procedure code afterwards, and with the noted changes, your findings, I should say, on that particular procedure code. The next few slides are going to be some practice slides on 15 lead ECGs, so here we go. So here is a 15 lead ECG, and you can see the changes. So remember, this would be your second 12 lead. So the second 12 lead, that means the first 12 lead you'd already have a copy of. The second 12 lead, leads 1, 2, 3, AVR, AVL, AVF, V1, V2, V3 should all be the same because essentially you did not move those leads. The only leads that you did move were V4, V5, V6. And that's why they're relabeled now. They should be relabeled to V4R, V8, V9. So essentially, when you're looking at the 15 lead component of that, or the second 12 lead, you can kind of focus your attention on the last 3 leads, which is V4R, V8, V9, to see what the changes are. So looking at these leads over here, what we can see is that V4R, we can see a little bit of elevation in there. V8, V9, we have some depression in there. So essentially what this tells us is that we have a right ventricular involvement from our inferior MI. So therefore, no nitro to be given, and it's not, there's nothing, it's not evolving to the posterior side. So this is basically an inferior MI, but with right ventricular involvement. So no nitro on this particular call, only ASA. This next one over here, if we can see the leads again, all that we're, you're seeing V4R, V8, V9, those are the changes. So if you look at those ones, look at V4R, if you're looking if there's any elevation or not, you see one of them has elevation, the other one does not. So a query on that one. V8, V9 does have elevation. So I'm not entirely convinced that there's actually elevation in V4R. So essentially, we have ourselves an inferior posterior MI, and I'm guessing that there's no elevation in V4R here, so I would say it's just a left-sided. So therefore, nitro could be administered. It would be up to 3 sprays only. Our next slide over here, we have our changes again, V4R, V8, V9. So if we look at V4R, we see elevation there. So this tells us that the MI, the inferior MI, is extended to the right side. So we have right-sided involvement, therefore no nitro right from the get-go. So we can tell that from initial onset. And then we can see V8, V9 is also elevated. So in this particular case, we have ourselves an inferior posterior MI with right ventricular involvement. So therefore, no nitro, ASA only, priority 4C test 1, and PADS application, the same thing, everything else. So a couple of little test questions to test your knowledge. So just making sure that people understand what they're looking for and looking at. So I'll give you time to think about yourselves or add responses or document your own responses before I respond. I'll respond to the answer. So here's a question: which leads view the posterior aspect of the left ventricle? So the answer here should be V8, V9. So remember, on the posterior side of the left ventricle, V8, V9, so those are the leads that we move from V5, V6, we move them to the back side. So these are the only two leads that look at the back side of the heart, so the posterior end. Next question would be, which lead views the right ventricle? This one should be fairly easy. It's the obvious choice, the one that says V4R, R indicating for V4 right. So that's the only lead that's going to be moved to the right side, looking at the right ventricle to determine right ventricular involvement or not. How many millimeters is required for elevation in V4R? The answer here should be 1. So remember, 1 millimeter is basically used throughout. The only exception to this rule would be V1, V2, V3. V1, V2, V3 require 2 millimeters of elevation. Those lead placements are actually over top of the left ventricle. So as you got a closer look, you need to be a little more accuracy. So that's why there's no more leeway. You need actually more of an accuracy there. So there's more millimeters required. Everything further away would require a minimum 1 millimeter. How many millimeters elevation in V8, V9 is required for a posterior MI? So same answer here. The answer here again is 1 millimeter. As I mentioned before, anything but V1, V2, V3 requires 2 millimeters. Everything else is only 1 millimeter. So in summary, again, a minimum V4R is required for when you see an inferior STEMI. That's for nitro consideration only. And 15 lead can be used as well. And can be acquired if ST depression is seen in V1, V2, V3, and or you're seeing also an inferior STEMI as well. So it could be just that or the depression or both combined. Though I didn't mention it earlier, but one question also was noted throughout the rounds is, would you do a 15 lead if you only had depression in one of those leads, so V1 for example? Typically no. I think the rule of thumb would be as at least 2 of the 3 leads, then you probably might want to do a 15 lead. But typically it's more common that if you're thinking of posterior, you would see all 3 leads be depressed. So V1, V2, V3. So that'd be the most common result, if you will, if you're suspecting a posterior MI. So, but at minimum, if you're unsure and you're seeing 2 of the 3 leads that are depressed, that wouldn't hurt, especially if that's the only thing you're seeing. Maybe you do a 15 lead at that particular point in time. So again, to finish off these notes here, a minimum of V4R is required for nitro. We talked about that already. And if the V4R is positive or elevated greater than 1 millimeter, then with an inferior STEMI, then of course no nitro at all. All right, so a couple more slides here before we wrap up. So a 15 lead ECG could be considered. So basically, looking at this 12 lead, would you do a 15 lead ECG? Okay, so the answer here is true, or yes, you would. Why would you want to do 15 lead ECG? Well, remember the requirements of doing such a lead ECG. And remember, first of all, you have to do your original 12 lead first, because your 12 lead is going to be, your 15 leads, or V4R for that matter, is based on your initial 12 leads. So there must be an initial 12 lead first, and then based on that, you're going to add on other leads to change whether it's required or not. In this particular case, there's three options whether you're going to do a 15 lead. One of them is whether you have depression, or elevation in leads 2, 3, and AVF, or depression is V1, V2, V3, or both combined. And in this particular case, we can see that there's depression in V1, V2, V3. So based on that, this would require a 15 lead, because this is likely maybe a posterior MI that we need to see. So we need to move some leads around. The following ECG warrants V4R if considering nitro. So looking at this 12 lead, would you want to do a V4R at minimum? If you're considering nitro for this person, would it be required? The answer here is actually false, or no, because the requirements for V4R specifically is we need elevation in 2, 3, and AVF, or we need an inferior STEMI. In this particular case, all we have is depression, which is not the same thing. So it does not require V4R. If it was elevated, of course we would, but in this particular case, it's all depressed. So no, we do not need a V4R, or we do not need additional leads here on this particular one. How about this one? The following ECG warrants V4R if considering nitro. So again, looking at this 12 lead, would you want to do a minimum of V4R if you're thinking about considering nitro for this particular person? And the answer here is actually yes, or true. So would you want to do V4R? Yes, you would. Why? Because if you look at 2, 3, and AVF, they're all elevated. So this would imply there's an inferior STEMI present. And if we're considering nitro, if he meets the parameters of nitro, if his heart rate is above good, he's got a history, or you have IVA access and whatnot, then you're going to want to do a V4R first to consider whether you can give nitro. Taking a step back here, having said that, if this patient actually did not meet the nitro requirements, had no history, or the heart rate was not within the realm, or he's hypertensive, then of course, regardless of whether there's a STEMI positive, inferior, or not present, then a V4R wouldn't be required, because essentially you're not going to be giving a nitro anyway, so you wouldn't have to bother with it. Question here, so based on this 12 lead here, so 15 lead ECG, so this 15 lead ECG now, so the changes you can see, based on this 15 lead ECG, would you give nitro or not? Yes, no, or not sure? And the answer here is no. Because again, if we're looking at this 15 lead ECG, so remember, V4R is specific for the nitro. That's the only lead that's required for the nitro. V8, V9 has nothing to do whether we're going to be considering nitro or not. So V4R is looking to the right side, V8, V9 is looking at the posterior side. So if I want to consider whether I'm going to give nitro to this particular person based on this 15 lead ECG, I'm just going to look at V4R. And in this particular case, V4R is elevated. So it's elevated greater than 1 millimeter, so therefore I'm suspecting that the right side is involved here on the right ventricle side, so therefore no nitro to be given on this patient here. On the posterior end, it looks like the posterior side is elevated, so that just tells me that there's a posterior involvement. But as far as nitro goes, this patient would not get any nitro. Simply ASA. That's the only thing he would get. So we got one more slide for you. So this question here is, what type of STEMI is this? So if you're looking at this 12 lead, what's your best interpretation of this 12 lead here? right, so having a look at this, if we're looking at this 12 lead again, the answer here is an inferior lateral reciprocal changes. So if you looked at all the changes here, you can see 2, 3, and AVF are obviously elevated. V1, V2, we have some depression in there. V3, not so much as borderline elevation in there, but V4, nothing in there. V5 and V6 has some elevation noted. And lead 1 and AVL has some depression, and AVR has an inverted, some depression and inverted T as well. So essentially, there's our interpretation would be an inferior lateral with the reciprocal change. So this concludes this presentation on the 12 lead review for your part of your spring rounds, for this year's spring rounds. I hope you enjoyed the presentation. I hope you got a little bit out of it. If anything else, hopefully the review is always good to review certain things, especially things that you commonly use. 12 lead is very skill that you will see often out there with patients, especially with the cardiac patients we have out there. So hopefully this helped you along the way. Hope the V4R 15 lead provided a little refresher for those who are still new to it or hadn't had a chance to use it yet. Hope you enjoyed the presentation, and this will conclude this presentation. Have a good day.